So I will introduce briefly Joost. So Joost, Professor Lumens, is working at the Karim Institute, which is the research institute of Maastricht, Netherlands, which is a small city near Göteborg. Joost is very funny, but also very good in hemodynamics.
Look who's talking. Look who's talking. There is also someone who is trying to be funny.
And
Sorry.
he is an expert in modeling, cardiac modeling. He is one of the father of the circadapp model, and he's very good in testing some hypotheses. And I guess he will explain his most recent research about pacing in preserved ejection fraction heart failure patient.
Yep.
So thanks for being here once again, Joost. And I let you present your work.
Thank you, Sylvain. I say Sylvain, sorry. I didn't record this because you said Professor Lumens. I can tell you all in the audience, he never said that. And I also, it feels very unnatural to hear that from him. I also don't expect that, of course, because just to tell you, I was in the Liryc Institute. Well, actually, the Liryc Institute was not existing yet at the time. That was 2011. I did a postdoctoral year in Bordeaux. I worked with Sylvain in the Liryc, and we did some nice research together in dysynchrony in left bundle branch block patients treated with cardiac resynchronization therapy. I see in the program that you will get quite some lectures about that. So it's good that I swap topics, because previous years I also focused on that, but then more from the modeling point of view. I will still show you modeling, and Sylvain, you already mentioned the way we use modeling in Maastricht mostly is for that, indeed, testing new hypotheses, things that you think of that may make sense, but that are not easy to check in vivo in patients, because you would need ethical approval, set up a whole study, and so on. And we use our model as far as that is can be used for those questions to get an easy check. And really, the story that I'm going to tell is exactly it went like that. Let me share the right screen. Now I'm gonna put it in presenting mode. Yes, now you see it. It is about a new concept, and that is pacing in heart failure with preserved ejection fraction. And I assume that, does everybody know what preserved ejection fraction means? Heart failure of preserved ejection fraction? Is that a familiar term? And I don't think I hear you now anymore because of, okay, I see thumbs up, so that's good. Let me make this a pointer. And yeah, so actually, and you see that also here, this is in Dutch, sorry for that, but I do have a disclosure here, and that is that part of this work is sponsored by Medtronic. And also Medtronic was actually the institution that came to us already a long time ago to check for a new ID, and that was patients with heart failure and preserved ejection fraction who currently don't have an indication for pacemaker therapy, at least if there is no other problem that needs to be treated. But HFpEF, clinical HFpEF diagnosis does not fulfill any of the pacemaker criteria in the guidelines currently. And just a brief recap. What is a preserved ejection fraction? Well, in the textbooks you will find, and in literature, that it has mostly to do with either a stiff myocardium or a badly relaxing myocardium, or both. Usually it's a combination of both, I guess. And that leads to difficulty of filling of that ventricle. So not necessarily a contractile problem. Contractile function in many of those patients, we think is preserved. And also there are some question marks, but at least the volumes are not as big as in the HFrEF patients by definition. What do you get if you have a stiff heart? It lost its compliance. Then the RAS system, so the homeostatic system that ensures proper filling of the heart, that also involves kidney function. You retain water, basically, to make sure that that stiff heart is still filled enough to deliver a normal stroke volume, and thereby, with normal heart rate, a normal cardiac output. You all know cardiac output is stroke volume times heart rate. Very simple physiology, I realize that, but it's important for this study. And if your heart is too stiff, then you get very high pressures in this left atrium. And that's bad. That's what makes patients feel bad, because you get congestion into the lungs and your lungs fill with fluid, basically. And that makes gas exchange difficult, and that makes people feel fatigued. They feel dyspnea, shortness of breath, certainly when you're trying to exercise. So that is the clinical phenotype of the syndrome HFpEF. Classical physiology here shows that I'm sure that most of you are hopefully everyone ever learned about this, the pressure volume loop here. So this is the stroke volume, that's the width of that loop. The afterload is the height of the loop, and then we have a preload, meaning this end diastolic volume that increases when you want to eject more blood. So when we go into exercise, the heart is filled better, and this pressure volume loop moves upwards at this end diastolic pressure volume relationship. You see that in a normal heart, this is a schematic representation of a normal functioning heart, that increasing the filling volume when we go into exercise does not necessarily lead to a huge increase in diastolic pressure, which is this pressure here, the bottom of this loop. And that's basically the pressure in the left atrium. So the left atrial pressure when we go into exercise, assuming that I'm healthy, increases a little bit, but not dramatically, not to a point that I get pulmonary edema, congestion. In patients with HFpEF, that's a totally different story. Those patients do have this huge stiffness. So the tangent of this line is stiffness, basically, is increased, meaning that for that ventricle to reach that end diastolic volume that is needed to produce the stroke volume to have a normal cardiac output, let's say 5 liters per minute at rest, this patient needs a very much elevated filling pressure due to the kidney function, again, as we said before. And in the end, that leads to an end diastolic volume that is relatively normal. So that's why it's a HFpEF patient with preserved ejection fraction. But the diastolic pressures are clearly elevated. And that's also the golden standard diagnostic measurement for diagnosing HFpEF. That is the filling pressure. So you have to measure the wedge pressure, and if it's above 15 millimeters mercury at rest, it's a definite yes that there is diastolic dysfunction. But in most patients, you try to do it with echo and describing the phenotype non-invasively. So this is a HFpEF situation, assuming that the myocardium is either not well relaxing or very stiff or both. Now, thinking about treatment in heart failure is that from HFrEF patients, we know that if you give them beta blockers, that you improve outcome. So at population level, you improve mortality and hospitalization numbers, rates, when you lower the heart rate. And that would look like, with a HFpEF patient, it would look like this. You actually force that pressure volume loop to operate at higher end diastolic volumes, because that's the only way to create a higher stroke volume. And if you lower the heart rate and you want to maintain normal cardiac output, you have to increase stroke volume per beat. And in the HFpEF patient, when this is the case, that is only possible by operating at higher end diastolic pressure, end diastolic volumes. But the consequence is that you also demand a higher diastolic pressure. And this is an exaggeration, this scheme. But it is true that if you lower heart rate and you want to maintain cardiac output in a stiff heart, in a stiff ventricle, then filling pressure at the long run will increase. And that's not good.
What?
And it is, there is...
What?
Good afternoon, sir.
Yes, hello.
May I continue my story, please?
Yes.
Sorry for that.
No worries. Okay, so you have actually a higher filling pressure, which is not good, because that's exactly what is causing the symptoms in those patients. Now, it is already known from clinical studies that HFpEF patients at a population level seem to improve if you stop beta blockade treatment. Still, people do it, but I think now currently in cardiology, there is a consensus that beta blockade is not the treatment for HFpEF patients, even though in practice, many cardiologists still give it. I know that. Now, this, if you follow this reasoning, it may be an idea to actually accelerate heart rate, to increase heart rate, because then you can have smaller stroke volumes, and therefore that same stiff ventricle doesn't need to be filled that much. But of course, you don't want to go through your daily life with 120 beats per minute. So there is a limit to this. Well, and because many of those HFpEF patients do have a relatively low heart rate, there is maybe a possibility to lower filling pressures by pacing these hearts at a slightly higher rate, higher than the intrinsic rate of those patients. And that is the hypothesis of this whole study. So it's based on the lower heart rate is better concept fails in HFpEF patients. That has been observed. And in theory, following the physiology that I just explained, patients with elevated left heart filling pressures may benefit from a moderate increase of heart rate. And that can be done with a pacemaker. Well, while we got that question from Medtronic and we were simulating this, because at that time we published a paper that we validated a way of simulating HFpEF. They spotted that, I guess, or heard about it. And then for them, it was very easy to get to us and ask, well, can you take your virtual HFpEF patients and increase heart rate and tell us what happens? So we were doing those simulations, and at the same time, early 2023, this randomized controlled trial came out, a clinical trial from the US, from mostly Marcus Meyer in Vermont and currently in Minneapolis. And they actually took HFpEF patients with a clear clinical indication, HFpEF, but with another indication for pacemaker therapy, any type of pacemaker therapy. And well, Sylvain can tell you much more about it, but what I heard is that the standard practice is that pacemakers are usually put at a backup rate, a lower rate that I think out of the box, that is 60 beats per minute. Sylvain, correct me if I'm wrong, of these devices. So that means that the pacemaker takes over when the patient's intrinsic rate drops below that pressure. Now, what they have done in this study is that they said, well, let's in one group, in one arm, we increase the rate to something around 80, between 80 and 90 beats per minute at rest, well, the setting of that device. And then they followed up those patients. And what they observed is quite a bit improvement in those patients, the light bars here, with a personalized accelerated pacing rate. So that is where the backup rate was about 80 to 90 beats per minute. Whereas the blue ones, they had the standard backup rate of 60 beats per minute or even lower. And they saw quite an improvement in quality of life, so questionnaires. They also saw an improvement, a drop in biomarker, heart failure biomarker, proBNP, whereas they saw an increase in the patients with usual care. And also they saw a rather objective improvement of patient activity, because this is derived from the accelerometers in the device itself. So the patient was not measuring activity him or herself. And that's quite an effect, as I was told. Then clinically, it's super important also that the device detected atrial fibrillation was much less in the arm where they were having a higher heart rate, a higher backup rate. And also the burden was less pronounced. Not huge differences, but if this can be reproduced in large randomized controlled trials prospectively in patients without an indication of pacemaker, it could be clinically very relevant. Okay, so what these studies didn't show was the mechanism. And also we are in very good contact with this group of researchers in the US, because they also approached us through Medtronic actually to do specific simulations to see why is this. And at that time, the effect on filling pressure was not so well known yet. It was a hypothesis by the researchers that could be the reason why AF burden is less. I mean, lower filling pressures is less stretch at the atrial wall, is less AF. So makes sense. So therefore, we use the CircuitApp model. CircuitApp model is a closed loop model of the heart and cardiovascular system, as we call it. It's developed here in Maastricht over the past, let's say, 25 years already. And we use it for teaching. What you see here is the user interface of the teaching tool that we use to teach medical students cardiovascular physiology and pathophysiology, focusing on pump function. You see pressures, You see volumes of whatever here, in this case, the left ventricle, the left atrium, but there's also the right ventricle and the right atrium in there. We have flow velocities across the valves. So this is ejection, the flow across the aortic valve. And in pink, you see here the mitral valve. Here you see some functional indices, you see a pressure volume loop, but this model is based on physics and all the physiology knowledge that we have about the pump function of the heart. So that is integrated in this mathematical model, and it's 0D, meaning that it's very fast. So that enables it to simulate faster than real time the function of the heart. And for pacing studies, for many of the questions related to pacing in the heart, this can be a useful tool to translate the electrical consequences that you will learn about from Marc Strick and Sylvain, how they translate into changes in pump function, which is sometimes harder to measure because that is not what the ECG can tell you. Okay, so at the time we use this, well, this is a schematic representation of that model because it consists of modules. So we have a module, for example, describing the physics and the physiology of a valve, a heart valve. And we use that same module. The physics is not different for the mitral valve, the aortic valve, the pulmonary valve, and the tricuspid valve. It's just the boundary conditions that is different and some properties of the valve itself, but its physical behavior is the same. At least that's what we assume. So in this study that was published 5 years ago almost, we were indeed focusing on, can we use this model to reproduce diastolic dysfunction of the left ventricle in red here? And also, can we then relate that to a decrease in exercise capacity, which is really typical for HFpEF patients? Well, that's what is shown here. So if someone is more of an expert in diastolic dysfunction, this is a mitral flow velocity, so the filling pattern across the mitral valve. You can obtain this with an echo Doppler measurement. And a well-trained cardiologist will always say, well, this is a normal pattern. This is passive filling and an active filling due to contraction of the atrium. Here you see that same pattern in a normal individual. When the E wave here is fusing with the A wave and it's lower, that is very specifically representing a relaxation problem. So the relaxation of the myocardium is not as it should be. And that's indeed what we modeled here. Also, when we decrease relaxation rate of the left ventricular myocardium, you immediately get this impaired grade 1 filling pattern, impaired relaxation pattern, just by changing one parameter. If we add a little bit stiffness to it, so we make the myocardium stiffer than it used to be, then you see that the pattern becomes normal again. This very much looks like this pattern. And that indeed in the clinic is called a pseudo-normal filling pattern. So you can have a patient with heart failure complaints, but then if you are going to make an echo, you see a normal sized heart, and you see the filling pattern seems not to be changed. But the trick here is that you have two problems at the same time, and if you have the right combination, apparently it gives you a pseudo-normal filling pattern. So from a diagnostic point of view, that's a tricky situation. You need more information to exclude a diastolic problem. If stiffness increases much more, then you get the typical very high peaky E wave, which is called a restrictive filling pattern. And also the model can reproduce that. And often you can also get a third peak here. I don't know whether, now this is the A wave, but sometimes you see this little peak here, which is called an L wave. And that is very well recognized and reported in literature as well. And our model, just by changing one parameter, well, produces that, meaning that it's simply a physical consequence of the properties of the myocardium that have been changed. Now, those 4 virtual patients represent a normal, healthy individual and 3 different types of diastolic problem. You can let them exercise in circuit adapt, meaning that you demand that same virtual heart to deliver a higher cardiac output here at the x-axis with, of course, a higher heart rate, which we prescribe. We know how much heart rate is supposed to increase with exercise. And then you see that the development of mean left atrial pressure here, in a normal healthy individual, it slowly creeps up, which is what we know from physiology. It shouldn't go very high because then you get pulmonary edema. If you have a relaxation problem only, you have normal filling pressures at rest, but they increase more rapidly when you go into exercise. If you have stiffness to it, so here in orange or in red, then you really feel bad because you see that if this patient reaches a cardiac output of only 8 liters per minute, it already has a filling pressure of 25, and already there, pulmonary edema starts to develop. And this patient really can't get out of the chair because at rest, you have already a filling pressure that is 25 liters per minute or 25 millimeters mercury or higher, because a normal resting cardiac output is about 5 liters per minute. That's here, you see? So this is really a bad patient. Okay, so our model is capable of reproducing this physiology just by changing 2 parameters of the myocardium. So where we continue with is this case now. Let's just assume that is the patient we are going to investigate. And what we then did is we increased heart rate, which is the most simple simulation that we can do actually. And to our surprise also, the filling pressure drops. And actually it's quite logical because of the physiology theory that I presented in the beginning, because in our model here, we assume that the kidneys can do their work and that they restore cardiac output to what it used to be. So in all 3 simulations here, 60, 70, and 80 beats per minute, the cardiac output is the same. That's what we enforce it to be. That means that at 80 beats per minute, this stiff heart can operate at smaller end diastolic volumes, and thereby the left atrium decreases from about, 13 and a bit millimeters mercury to almost, 11, 10. It's not much, but it might be clinically relevant. And then what the model also predicts is that if we increase heart rate to higher heart rates, so we increase heart rate too much, you see that in the end, actually filling pressure increases, the mean left atrial pressure. And that's not what we want. Well, that's not really a big problem because I think none of us would be willing to have a resting heart rate of 100 beats per minute or even a lot higher. So we're not so interested in this area anyway, but it can be relevant for validation purposes. Okay, but what happens in patients? So at the time we had these results, and at that time the MyPace study that I presented earlier was not out yet. I presented this to the head of cardiology here in Maastricht, and he said, I asked him, well, can we maybe check this in vivo? And a few days later, he came back to me and he said, well, I have an idea. Because on a daily basis, also in Bordeaux, many of these patients are treated on a daily basis. Those are patients with paroxysmal AF, and they're being ablated. So they get a PVI procedure, pulmonary venous isolation, and in this procedure, there is standard a lead in the atria. Actually, I think it's in the coronary sinus, so that you can always sense and pace if needed. And they have a transeptal pressure catheter. So this blue one is a pressure catheter, and it can measure directly the filling pressure because it's in the left atrium. So now we have the tools available to actually to measure or to perform our simulated protocol, meaning we can pace at higher rates and we can measure pressure. And what is a nice coincidence is that we know that AF patients and HFpEF patients have huge overlap. There is about 50% overlap in those populations. HFpEF patients very often end up with AF, or the other way around. AF patients can develop HFpEF. It's certainly a mixed and overlapping population. So we actually did a little protocol to test our hypotheses or our predictions of the model. We started at the intrinsic resting heart rate. We increased for 1 minute or 30 seconds. We increased by 10 beats per minute. We went back to resting heart rate, or intrinsic heart rate, I should say, because the patient is sedated, so the heart rates are relatively low. Then 20 beats per minute higher, back to intrinsic rhythm, and so on, until we reach Wenckebach rhythm. So during these phases, we can actually measure we have the ECGs on the monitor, and we have also the pressures measured by this pressure catheter. So we can have a beat-to-beat tracking of heart rate and pressure in the left atrium. And that's, of course, in a very acute situation. Well, this is an example. What we see here is the ECG. We have the CS lead here. You see here the pacing artifact. So then you know exactly when the atria are paced. In this case, it's septal pacing. So a very, I think, proximal electrode in the CS. And what you see is that in sinus rhythm, this patient has a low heart rate and has a mean left atrial pressure that is already elevated. It's not terribly high, but it's 11 millimeters mercury. And if you increase rate by 10 beats per minute per step, you see that filling pressure indeed drops to 5.6 liters per minute. Millimeters mercury. What we don't know in this study is what is the cardiac output at this rate. Okay, so it decreases. You also nicely see that here in the tracings measured. And also what we observed is that if we go further, that the filling pressures increase again, exactly like the model predicted. And that's not a big surprise, because we end up with a situation where there is basically no more filling time. The heart rate is too high, and the atrium is contracting against a closed mitral valve. And that's explaining this huge peak here, this very sharp high peak. That is actually the atrium contracting against a closed valve. You can also see that here, because you see, let me see, we have here the P wave, P wave, P wave, P wave. And look, here the P wave is going to fuse with the repolarization, it also means it's actually in the relaxation phase of the ventricle. And if you go on, you don't see a P wave anymore because it's here in this T wave. So it's actually contracting when the mitral valve has not opened yet. And that explains this increase in pressure. So that is a very nice validation of the model. Well, we did this in 75 patients, and almost in all of them, or basically in all of them, the filling pressure decreased. It's not much. It's just 2, 3, 4 millimeters mercury, but it might be relevant. Might be relevant. We don't know. Okay, there is a very important additional finding that we see here, and I can show you, because that gray bar is actually the time between the pacing artifact in the atria and the QRS complex. So it's the PR interval, and the PR interval with pacing rate increases. Well, that's well known that happens because in our human body, the PR interval reflects the AV coupling. So it's caused by the delay of electrical depolarization in the AV node. And if I go into exercise, and you as well, you get sympathetic stimulation of the heart, including the AV node, making sure that the AV node conducts faster, that the PR interval gets shorter when our heart rate increases. And that's not the case here, because we increase heart rate without any sympathetic stimulus. So you're making an artificially high heart rate, and you see that the AV node actually doesn't like that. It increases its or decreases its conduction velocity, leading to a long PR interval. And that is really a problem, because if you have only, here in this case, 120 beats per minute, is a RR interval of 500 milliseconds. And if you have a PR interval of more than, let's say, 300 milliseconds, there is no more time left for filling, nothing. And that's exactly explaining the problem from a pump function point of view here in those high rates. So we see that PR interval increase actually also happens in almost everyone. So that's a problem. We actually we mess up the AV coupling, which is not good for the pump. Despite that, we do see a decrease in filling pressure. And the question now was, well, that PR interval, the lengthening, how bad is that actually? How much of a hemodynamic disadvantage does it give you? Because, you know, if you solve one problem and you create another, then in the end, the therapy won't work. And that's when we went back to our computer model, because in our computer model, we can not only change pacing rate, but also PR interval. So we can make PR interval any value that you would like. If it's 0, it means the atrium and the ventricles are stimulated at exactly the same moment, which is also not physiological. But if it's 300, you end up in a huge problem at high heart rates, because there's no more time left for filling, as I said before. And let's start with the condition of a constant PR interval of 150 milliseconds. What you see then is that if we are now going to simulate every point here in this matrix, and that's the nice thing about a model, you can simulate every data point in that 2D parameter space, and you can say, well, how high is the mean left atrial pressure, given the fact that we have a heart rate of 80 and we want a cardiac output of 5 liters per minute. So in all those patients, the cardiac output is the same, 5 liters per minute. It's only the heart rate that is different, and the PR interval. And then you see what we already observed is that by increasing the rate, the color becomes more blue. And blue means lower filling pressure, which is good. If we then project actually the PR lengthening, like observed in the patients, on top of this color scheme, we see exactly, so the colors are the predictions of the model, and it represents filling pressure. And these dots here are actually the PR intervals averaged over the 75 patients we had at each heart rate. And then you see it increases, as I already showed. And then you see typically this, so if you look at the color, it's green, it becomes blue, so it decreases. Then it becomes green again, it increases, and it becomes yellow and red, which means it's higher than it used to be at intrinsic rhythm. And that's exactly what we observed in that patient that I showed, and also what the model predicted with this situation. Okay, that's not where we want to be, of course. But if you look at the full space, you see that the model says the optimal relation between pacing rate and PR interval is that the PR interval should decrease a little bit. And that's exactly what is normal, healthy physiology, I would say. If my sinus node increases heart rate, it's usually because there is a sympathetic stimulation, and that also increases conduction velocity in the AV node, meaning that PR interval will decrease. And that also leads to the minimum filling pressure. And that's what we think evolution took care of. Huh? So the model predictions say, well, if we would be able to control ventricular activation as well, that would be great. And if you overdo this, it's also not good. We knew that already also from the CRT studies. Okay, but what happens with this if the atrium is not as healthy as it used to be or should be? Because everything I showed you so far assumes a normal atrial myocardium, and patients with AF never have a normal atrial myocardium. Well, here you see the difference. This is the plot that I already showed you, showing nice, this sweet spot, let's say, of blue color, meaning that that is where the filling pressure is really being reduced by an increased pacing rate. Here you see, if we have atrial contractile dysfunction, that it becomes less blue. That means there is less benefit to gain. Well, if you then extrapolate that thinking, you can say, well, the worse the atrial myocardium and function is, the less benefit we would expect in terms of absolute drop in filling pressure by accelerated pacing. That's important. That may help us to set up proper inclusion and exclusion criterion of a future trial. Okay, so well, summarizing, atrial dysfunction attenuates the unloading response of accelerated pacing. And with that, I've reached the end of this story. This paper has just been published, actually a week ago. It appeared in European Heart Journal, so the combination of the simulations and also the in vivo data. And the nice thing, what I really like about this is because we think we capture the mechanism quite well now, you can also think about the next step. Well, you have seen that AV coupling is important. You've also seen that increasing heart rate with only an atrial lead increases PR interval, which is not good. So now in those times of conduction system pacing or physiological pacing, you could think, well, maybe we could also do AV sequential pacing, not only increase the rate of the atrium and the whole heart, but also have a ventricular lead such that we can time the ventricular contraction well to that atrial contraction. With conduction system pacing, of course, because you don't want to make a synchronous heart in terms of the ventricles asynchronous by a pacing. Then you treat one problem and you create another. But this is wishful thinking maybe. But at this moment, there is a large trial ongoing, sponsored by Medtronic, really a big one. A lot of centers worldwide are including patients, but I think this is only atrial pacing. So what we are trying to set up now here in Maastricht is to do an acute study like this one, but then with an actual pacemaker implantation in real HFpEF patients, no AF patients, but HFpEF patients, and see if we additionally also control AV coupling, whether we can even obtain more benefit for those patients. But that's a very provocative study because it's off-label use of a pacemaker in patients who have no real indication to have a pacemaker. Well, there are many people contributing here, but mostly we are in very close contact with those people from Vermont and Minnesota, especially Marcus Meyer. And in the clinic, it's really Kevin Vernoy who actually did most of those measurements in the cath lab, together with Justin Lumens. And our heart failure cardiologist, Vanessa van Empel, she actually sees all the HFpEF patients in Maastricht. So she is very important for the follow-up study. Well, I hope this gives a very nice also impression about how we use modeling together with in vivo measurements. And when the in vivo measurements teach us something, or we observe something we didn't expect and we don't know the mechanism of, we go back to the model. And from those predictions, we go back to the clinic again. So we continuously go back and forth. And we hope this accelerates innovation in cardiology in general. And Sylvain, you know this as well. For this type of study, 20 years ago, we would have used dogs to test it instead of the model. So I dare to say that we also provide quite a nice alternative to experimental animals. I'm not saying that this can replace all experimental animal studies, for sure not, because there are lots of things that we cannot simulate that are important. But at least for these kind of studies, more the organ, tissue, and system level studies, it's a good alternative. Okay, I talked a lot. Are there any questions from the room, maybe? You have a microphone, I think, if that works.
Do you hear me?
Yes, very well.
Very well. Nice. So I was wondering if you want to test the study in real patients, how are you going to define the pacing rate? Will you look at their measurements and then look at your model? What would be their optimal pacing rate, or are you just going to say we try 80 now? And
yeah, very good question. We have discussed at length about this. What the study in Vermont did, they call it also in the title personalized accelerated pacing, because they have a certain rule that I don't know exactly where they got it from, but it's from large population studies where they say, well, if you're that old, if you're that, let's say the BMI, I think big, the BMI, age, and gender, those three ingredients together tell you what would be the ideal physiological heart rate at rest. And that's what they used in their study. Whether that is optimally in terms of hemodynamics, there is no data on that. In our study, you could say, well, if you do the acute check first and you observe that a certain heart rate gives the lowest filling pressure, then you stick to that. But the unfortunate thing is that mostly the lowest heart rate, I can go back, see if I can find that slide. You see that then you end up at heart rates of about 100 beats per minute, and I think that's a little bit too high. I think if you have at rest a heart rate of 100 beats per minute here, that's the median, that's quite high. But what my PhD student did, he said, well, I take the minimum left atrial pressure and define that as the optimal rate. But what we see, and also in that example patient here, you see that going from 60 to 70 to 80 already, decreases filling pressure by more than 4 millimeters mercury. And I think that's sufficient. So what we're going to do in this study, we actually stopped discussing about this and we said, well, let's make it 85, because 85 is a relatively normal heart rate at rest. And we know for sure that you obtain benefit there. And it doesn't feel like you have you have high palpitations all day. So it's not more intelligent than that at this point. No. Maybe you have another suggestion or another thought. Other questions?
Not really, I think. Anyone have questions? I don't think so. No other questions. Or do you have one?
Yeah. Do I have to push? If you set the heart rates at 85 as a continuous value, what will happen during exercise, for example?
Yeah. So when this patient goes into exercise, then it's a backup rate, and then the sympathetic drive of the patient, him or herself, will drive the sinus node to higher rates anyway. So then the pacemaker is not relevant anymore. So you're not pacemaker dependent in that case. There still are a lot of questions. Well, should you not also increase rate at exercise? That's an open question. We are still working on that, and there's also other groups working on that. There's no definite answer to that. No.
All right, thank you.
Hello.
Then,
yeah. I have a question regarding how can you mimic an increase in AV in the conduction system with a pacemaking strategy? Have you thought about how to do that?
Do you mean in the atria of the ventricles?
So the conduction system is you need to have if I understand correctly, you need to increase you need to have to pace both the atria and the ventricle, if I'm correct.
Yes, well, to increase the rate, that's why you pace the atrium.
Mm-hmm, yes.
And then that also brings up the question, where are you going to pace the atrium? That's an open question, because you can pace in different, a standard atrial pacing lead is in the right atrial appendage.
How can you mimic the PR interval by pacing?
Yeah, for that you would need also a ventricular lead. That's that's an obligation. I mean,
So it would. How could you control the delay between the two, or what will be the parameters?
This is something you can program on a pacemaker. So we call that the EV delay. It's
Okay.
It's like a PR interval, but electrical right, EV delay. And so you can program any kind of value for this EV delay, and all the pacemakers are designed to decrease this EV delay with the heart rate.
Okay, I see.
It would correct this lengthening of the PR.
All right.
We are talking about.
All right. Okay.
What
Thank you.
And you have.
What also Joost said very importantly is that if you do that, you will force the capture of the ventricle, and this capture will induce interventricular dysynchrony. So this is why Joost suggests to use physiological pacing instead of conventional pacing, because then you reach. Mark will explain you in few days what is a physiological pacing, but shortly it means that you pace the Purkinje system, and then you get synchronous activation of both ventricle.
Well, that's the ideal situation, but in practice, of course, it's not always so. So I think, Sylvain, because do you do a lot of conduction system pacing at this point in Olivec? Yeah.
Yeah, I would say 60-70% of all the patients.
Yeah. And then you do left bundle branch pacing?
Yeah.
Or yeah.
Yeah.
So yeah, you know, it's that whole movement towards conduction system pacing really puts this story in a different perspective, because before that time, I mean, 15 years ago, people would say you're crazy because you're messing up a synchronous ventricle with a pacemaker. So you're creating on the long run, maybe even pacing induced cardiomyopathy, which we know can happen. Just a little addition for you all, and maybe also Sylvain, you're interested in this, is what to do with atrial pacing, because the group in Vermont, do you know Daniel Lustgarten, maybe? But he has published a lot about Bachmann bundle pacing. So he advocates, well, also in the atria, you have to do conduction system pacing by hitting the Bachmann bundle, which is part of the fast conducting system in the atria. And that is also something we have simulated. Let me see if I can share that.
Because in your study with Kevin, you paced the left atria through the coronary sinus, or the right atria?
We paced, I think it was 9-10 or something. It's a very proximal position in the coronary sinus. So it's actually atrial septal pacing, which in practice you would never do. But it was because we had to pace from that coronary sinus lead.
So it's not a very, it's the worst, probably, or one of the worst situation, because then the atria is contracting reversely from bottom to top.
Yeah.
So we could think that a higher, like for example the bundle ridge you mentioned, would be even better in reducing.
It can even improve it. Yeah, absolutely. So if it would make a difference, it probably would be in the good way.
Yeah, exactly.
Well, we have simulated this. So we got these data, and I have to say these data are not ours. Those are from Daniel Lustgarten. You see P wave duration in paced configuration and sinus rhythm. And here you see patients with right atrial appendage, meaning you are lengthening P wave duration mostly, because the dots are mostly on the prolonged side. And with this RA septal pacing, what we were doing, it's not, in some patients it's worsening the PR duration, and in some it's shortening, but mostly worsening. And with Bachmann bundle pacing, look at this. All those patients show a shorter P wave duration. So that's quite promising. Well, that is what we also, let me see, what we tried to simulate. So we translated this to CircAdapt. So we have here the strain patterns in the atrium. And then you see with Bachmann bundle pacing, you see most synchronous mechanics as well of the left atrium. Whereas here with right atrial pacing, appendage pacing, it's very asynchronous, which is not good for pump function. And also when we increase rate with those three different atrial pacing configurations, you see that most decrease is absolutely obtained with Bachmann bundle pacing. That's a prediction of the model. We have no clue whether this also translates into the in vivo situation. But Kevin is actually testing this now. So he's doing cases where he does RAA pacing and Bachmann bundle pacing in one procedure, and then measuring whether it makes a difference. At least this is what the model predicts, and we hope the in vivo situation is similar, qualitatively at least. Yeah. So yeah, that's everything I have at this point.
I'm sorry, I have to leave because I have another meeting.
Yeah.
Thank you
No
very
worries.
much.
Thank
Joost.
you.
It was wonderful as usual.
Yeah, thank you. And you can leave, Sylvain. If there are any questions left from the audience, I'm happy to take them and also to reflect maybe a little bit more on the job or anything that we have, and integration of modeling and clinics. I don't know what your thoughts are, and if you have any more remarks or questions, please go ahead.
Could you tell more about the how you use modeling in Maastricht, like this?
Yeah,
I'm really interested in that. I don't think there are any more questions here now.
No. Okay, thank you. No worries. So yeah, well, I think this example speaks pretty much for itself, meaning that we use models to have a quicker and still reliable answer to specific research questions that can either come from the experimental labs, so from animal labs, the more basic research, but also from the clinical lab, which this is a clear example from. So in general, we have two types of application. That is more preclinical, that's really basic research. So we do also have a coupling of a new contraction model at the subcellular level, where we model explicitly the actin and myosin filament interactions, the role of calcium, the role of titin, all these kind of subcellular processes that underlie a cardiac beat, basically. We can actually simulate at pretty much, well, faster than real-time level, which also makes that we can bridge observations that are obtained in animals with very specific cardiac diseases, often mutations, congenital cardiomyopathies, maybe. We can translate those animal findings to the clinical context, because we cover subcellular, cellular, tissue, organ level to system level. We have the whole circulation in our model, and that is needed to relate cellular observations in the experimental lab here to symptoms of a patient, which is a much higher level. So in general, that is what we use the model for, to bridge pieces of knowledge and to get to well-educated new hypotheses, which you then can go and try to confirm or reject in a new experimental or clinical in vivo study. So you could see the modeling that we do as a research accelerator, basically. That's one way to look at it. Then the other thing that I wanted to add is that what you have seen now is what we call a forward simulation study, meaning we have a model, we can change parameters, and then observe what does that do to pump function, or in this case, mean left atrial pressure. Now, what we are also working on is a concept that I'm quite sure some of you may have heard of, that is digital twinning. So we make also digital twins with this model, meaning that when we have non-invasive, preferably non-invasive information, diagnostic information available from the clinic, from an individual patient, we try to change parameters of the model to reproduce those measurements, and then hopefully obtain a unique solution to that set of measurements that tells us, how low is contractility, how stiff is the myocardium, things that we cannot easily measure in vivo. And if you obtain such a digital twin that you have proven to be reliable, meaningful, and certainly also unique, because there must never be two combination of parameter values that lead to the same phenotype, because then you don't know which is true. If you have that, you can do this type of pacemaker therapy first in the digital heart before you do it in the actual heart of the patient. And that is what we are working on, and that is also what, that's not something for the far future. That's something for the next years to be possible. And we published one paper on that in a cardiology journal as well. Yeah. Well, that's a long answer to your question, but it's more a philosophical question, isn't it?
Yeah. No, I think it's really interesting as well about the digital twinning, because then you can get like a proper personalized pacing strategy, I think, instead of only using the few parameters they used. Yeah. Exactly.
But I hope you all realize that digital twinning is a super concept. Formula One does the same. So Formula One teams, they all have a digital twin of their car, and they're continuously developing and optimizing the setup of those cars to specific conditions. Well, we do basically the same, or we try to do that for the heart of the patient. But you're always bound and limited to the available clinical data. And often that is not much. So if you have a very complex model, it goes wrong already, because then the complexity of your model does not fit the availability of the data. You get an ill-posed problem, and then you can't get a reliable digital twin. Yeah. Okay. No more questions?
I don't think so, no.
Okay. Thank you, guys, and my apologies for not being in Bordeaux. But yeah, maybe we meet once in the future. I wish you all the luck with your master studies in Liryc, and enjoy the wine as well, I would say. That's a
Thank
bad
you.
thing about in Bordeaux. I got addicted to wine, so that is a leftover from it, and it's not the best leftover, I can tell you. It's an expensive one as well. Okay, enjoy. Cheers.
Okay, thank you. Have a good evening.